So good morning, everyone. It's nice to see so many people participating in Grand Rounds today. Despite the snow, I see 65 people already, and the numbers going up as we go past 7:30 here. So this morning, I'm really pleased to introduce Chris Burke, who's going to talk about the living aortic valve complex. As you all know, Chris is one of our cardiac surgeons here at the UW Medical Center. And, he's been a fantastic addition to our group. He did his undergraduate education at Brown University, followed by medical school at the University of Michigan, which I know is an alma mater for many of you. And then he went on to join us in Seattle for his combined cardiothoracic surgery residency, a 6-year program in cardiothoracic surgery, including time at Seattle Children's Hospital as an ECLS fellow there. After his training here, he went to Philadelphia to do an advanced aortic surgery fellowship, which I think training his, as he's finding out, is serving him in very good stead here in Seattle. And, we're very excited to hear him talk today because things are really starting to change for aortic surgery and aortic valve surgery. I mean, we're going from an era where we had, very few options in terms of interventions, mostly valve replacement, to more and more complex and interesting procedures as we begin to understand the valve and aortic anatomy and options to retain the patient's own valve rather than replacing it. And I think these are really going to change how we manage patients over the next decade. So we're up to 87 people today, and I know there's a lot of interest because this is a really important topic. So I'll turn it over to Chris, and we'll go ahead and submit your questions in the Q&A or in the chat, and we'll try to answer all those at the end. So Chris, over to you.
Wonderful. Well, good morning, everyone, and thank you, Dr. Otto, for that very kind introduction. I have a fair amount to get through about the living aortic valve complex, so I think we'll just go right into it. I have no relevant disclosures. I have some objectives listed here. The first is to understand the long-term consequences of AVR in young patients. And then I'll be introducing the concept of aortic valve sparing and aortic valve repair approaches. And then we'll finish by discussing the role of the Ross procedure in a modern aortic practice. So I think it goes without saying that mitral valve repair techniques have been refined significantly over the past 30 years or so. And valve repair is really standard of care now for mitral regurgitation. And this is in stark contrast to the situation on the aortic valve side, where treatment options have tended to really center around valve replacement. And aortic valve replacement is certainly a well-established and reproducible procedure. It is well within the armamentarium of any practicing cardiac surgeon. It allows placement of a mechanical or bioprosthetic valve prosthesis. And with really the revolution in TAVR that we've seen in the recent decade, we've really seen a stark increase in bioprosthetic aortic valve replacement. And this is even translated into younger patients with the promise of future valve-in-valve TAVR. However, I think it's critical that we recognize that aortic valve replacement does result in future morbidity and excess mortality for patients. And as I'll point out, this is especially true in our younger patient population. And so this is just illustrated here in this figure. And this is long-term survival for patients, and the shaded diamonds are those after aortic valve replacement, and matched controls are shown in the open diamonds. And you can see there the difference in those two curves is excess mortality over time. And sort of to further drive that point, I found this study to be very, very compelling. This is data from a group in Montreal looking at isolated mechanical aortic valve replacement in young patients defined as those less than 65 years old. They excluded a lot of higher risk situations, aortic dissection, endocarditis, etc. And the mean age here in this cohort was 53 years. So there's good follow-up for these nearly 470 patients out to an average of 9 years. And here again, you see a similar figure. So matched controls in green, and then again, an isolated mechanical AVR population in blue. And you can see, out past 10 years, patients in the mechanical AVR group are falling behind sort of their matched peers in terms of long-term survival. And I think the most interesting figure from this paper is shown here. So this is long-term survival free from reoperation. And if you go out to 10 years, nearly 1 in 5 patients is dead or reoperated upon. And again, these are young mechanical AVR patients. And so I think the point of all this is I never tell a patient that if they get a mechanical aortic valve replacement, they will, quote, never need surgery again, because it's just not true. And in fact, 2 days ago, I operated on a young patient who had previously had a mechanical AVR. So again, aortic valve replacement is associated with excess mortality, and I believe patients do fall off the expected life curve. And this is true even with mechanical AVR, and especially in younger patients. Aortic valve repair allows for restoration of what I'm terming the living aortic valve complex, retaining a patient's own biologic tissue, which I think has advantages, and potentially decreases long-term morbidity and mortality seen with AVR. And this just shows this a little further. Again, by retaining that living tissue within the aortic valve with either a patient's own leaflet tissues in the case of a valve-sparing root or aortic valve repair, or using a pulmonary autograft in the case of a Ross procedure, I think this results in several things. Number one, excellent hemodynamics, low thrombogenicity, and resistance to infection. And this ultimately leads to no need for anticoagulation for these procedures, fewer valve-related complications, improved quality of life, and potentially a survival advantage, though some of that will still need to bear out. So I want to organize the remainder of the talk focusing on 3 different patient groups. The first being aortic insufficiency with root aneurysms, the second being sort of isolated aortic insufficiency without root aneurysms, and the third being a conversation on aortic stenosis in younger and middle-aged patients. The treatment paradigms are going to be very different for these 3 groups. So we'll start with the first group, again, aortic insufficiency with a root aneurysm, which is shown on the figure here to the left. And these are classically treated with a composite valved conduit, shown in the figure on the right. And that's termed a Bentall procedure, where both the aortic valve and aortic root is replaced. And you can see the coronary buttons reattached here to this graph. And again, we can use mechanical prosthesis or a biologic. And this is, although a technical step up from an isolated aortic valve replacement, still I would say a relatively straightforward operation that certainly should be in the armamentarium of pretty much every cardiac surgeon. However, there's been a lot of interest in valve-sparing approaches to root replacement. And these really took off in sort of the 90s and early 2000s. And there's really 2 general varieties of valve-sparing root replacement that are shown here. The reimplantation technique, or David 5, where a Dacron graft is brought all the way down to the level of the aortic annulus to stabilize the annulus. And then the valve is reimplanted within this graft, and you can see the coronary buttons there. That's in contrast to the remodeling procedure, or the classic Yakub, where a scalloped graft is brought down onto the aortic valve. Coronaries are attached. Now, there's been a lot of technical reiterations, especially the Yakub operation. You can see the David operation is on its 5th iteration. It's a little bit beyond the scope of this talk to get into all the different varieties, but in terms of the classic remodeling or Yakub procedure, the mode of failure was with late aortic annular dilatation and aortic insufficiency. And again, in the classic sense, the reimplantation was felt to be a better operation due to the protection of the aortic annulus from future dilatation. Now, again, there's lots of contemporary uses for internal and external annuloplasty rings that we'll talk about, but again, a little bit sort of beyond the scope of this discussion. So where do things stand now? I would consider a valve-sparing root replacement to basically be standard of care at this institution for root aneurysms with a repairable aortic valve. And we use this operation in a variety of settings. We use it to repair aortic valves that have significant aortic insufficiency. I've done several patients now with acute type A aortic dissection. There's some technical nuances, but that's very feasible. And it's certainly an excellent operation in patients with bicuspid aortic valves. So let's just take a look at what this looks like in the operating room. This is a 59-year-old with a 5.5 centimeter root aneurysm. Here's the pre-op echo, very little AI. This is a beautiful tri-leaflet aortic valve. As in any root procedure, we're mobilizing the coronary buttons. That's the left coronary. This is a very important dissection. Here I'm getting below the level of the aortic annulus on the outside of the aortic root. This is a fairly meticulous dissection here, and we're really delivering the aortic root out of the heart to again get below that aortic annular plane. That's a beautiful valve. I'm just measuring the annulus here. It's a bit dilated, about 29 millimeters or so, as you can see. So we'll use a 32 Valsalva graft in this case. And here's our primary aortic suture line. So these are subannular stitches that are going to be attached to the base of our Valsalva graft. And again, this is the portion of the reimplantation that helps stabilize that annulus from dilatation further down the line. So I'm just tying down those stitches now. And then we reimplant the commissures next. So we get them nice and high on the graft. And then those get tied down, and we'll do our secondary aortic suture line. This is our hemostatic suture line. This is so obviously very important. And here we go inside and out of the graft, actually. There's a little bit of prolapse on the non-coronary cusp, so I just did one simple plication here to raise the height of that leaflet, and I got a little bit better coaptation of the leaflets after doing that. So the coronary buttons come next. And again, this is standard for any root replacement. And we start with the left coronary button that's being shown here. So this is how we reattach the coronary arteries. And we'll do the left and then repeat that process on the right, obviously. Always important to do a final valve assessment. You can see we have a significant reduction in the annular size. That was a 25 dilator. It was 24 pre. And we get the degree of annuloplasty by the size of the graft that we choose, and a beautiful result postoperatively with no AI. In terms of durability, this is data from Tyrone David himself. And so in fairness, these are results that we all aspire to obtain. But certainly in his group's hands, this is an excellent operation. Very low rates of aortic valve reoperation all the way out to 15 years. very low rates of recurrent or new aortic insufficiency from a moderate or severe degree, shown there on the right. And this holds true even for patients with bicuspid aortic valve. So this is again Tyrone David's series, and the 10-year risk of valve reoperation was less than 5% for patients with bicuspid valves, and 1.5% for those with trileaflet. A few sort of things that I listed as kind of controversies, if you will, and considerations. And one thing that I'm noticing is coming up a lot more in national meetings is this idea of comparing reimplantation, or sort of the David type operation that I've shown, versus a remodeling with annular stabilization, again with some combination of internal external annuloplasty rings. I'm worried we're sort of finding a solution where a problem doesn't necessarily exist. Both of those operations are excellent procedures. The data I've just shown you is fantastic for reimplantation, and I think I'm worried we're sort of focusing a little bit too much on these various ways we can do things. And I would encourage surgeons to really find a technique that they're comfortable with and can reproduce, and go with it from there. Another thing that's kind of interesting that comes up quite a bit is there an upper age limit to these procedures? I may be a little bit embarrassed to admit, I operated on a 78-year-old and did a valve sparing root last year. I actually saw him in clinic on Monday. He's now 79. His echo looks absolutely perfect. He's happy as can be. This is a quote from my mentor, Joe Bavaria, who says, "Hey, if the valve is perfect, go for it," which I think holds true. And somebody probably in their late 70s, we would certainly have no hesitation to repair a mitral valve in somebody in their 70s. I think if patients are in their 80s, you're probably getting into a little bit of a diminishing return situation at that point. And then the last thing I listed here was the distal aortic extent. So we've been focusing on the root aspect, but one thing that comes up, and I kind of listed here, is to hemiarch or not to hemiarch. So what patients should get sort of automatic arch operations? And this comes up the most with those with connective tissue. So you're doing a young Marfan patient. Is it mandated to do a hemiarch in that patient to get rid of the aortic cannulation site and the cross clamp site? And I would say we don't know. And we're actually actively doing a project here to help answer that a little bit. I think the only patient population that I think is fairly clear on that is those with Louis Dietz. Any patient with Louis Dietz, I do at least a hemiarch on, again, to resect any aorta that's been manipulated with either a cross clamp or an aortic cannula, because we have seen patients come back with aneurysmal degeneration. So I want to shift gears to the isolated aortic insufficiency group of patients. This is more challenging. This is those without a root aneurysm. And I'll start with this general comment where, whereas valve sparing root replacement, I would say is a quite well established and generally reproducible operation, certainly in high volume centers, primary aortic valve repair has proven to be a bit more challenging. And so why is aortic valve repair difficult? And I listed a few thoughts here and contrasted each with the situation for mitral valve, which, as I said earlier, is very standard for repairability. So the first thing, at least in the case of a trileaflet aortic valve, we have 3 lines of coaptation that we have to deal with. And that is in contrast to 1 coaptation line in the mitral valve, obviously having 2 leaflets. With aortic valve, there's always a delicate balance between treating regurgitation and inducing gradients. And these things are often, as you get more aggressive about taking regurgitation away, you can have issues with gradients, and I'll go into that a little bit more. It's quite frankly fairly difficult to create mitral stenosis. I mean, the most amazing thing is the Alfieri stitch, where we're literally sewing the middle of the mitral valve closed, and most of those patients don't develop mitral stenosis, which is pretty much amazing every time I see it. The aortic valve leaflets are less amenable to resection and reconstruction and patch techniques and things like that. And that's in clear contrast to the situation in mitral valve, where the posterior leaflet is very routinely resected and reconstructed as a really standard part of many repair techniques. And I think in some ways the aortic annulus is a little bit less accessible surgically. It's in a high pressure environment. As we'll see in some of the videos I show, it's a little bit trickier to sort of work with the valve intact. And that is in clear contrast to the mitral annulus, where the left atrium provides a very accessible low pressure environment that's very amenable to an annuloplasty ring. That said, in the past decade, there's been a lot of interest in aortic valve repair and various techniques. Most of this literature comes from Europe, actually, although there's becoming a lot more enthusiasm in North America. And I would say that there's been good medium-term results with both tri-leaflet and VAV repairs. El-Khoury published a very useful classification scheme for various mechanisms of aortic insufficiency. And I think this provides a nice framework for thinking about these patients and how to treat them. And if it looks similar to something you've seen before, it is very much akin to the Carpentier classification for mitral regurgitation. And I'm not going to get into all the details of all these lesions, but in general, patients with what are considered type 1 classification would be those with normal aortic valve cusp motion. And these are usually what we think of as some sort of functional annular dilatation, either at the commissure segment from an ascending aortic aneurysm, or down at the basal ring segment, or even just isolated annular dilatation without any aortic aneurysm. We'll kind of skip 1D. Type 2 lesions involve cusp prolapse, and these are a little trickier. So this is true leaflet pathology here with failure of coaptation due to a prolapsing leaflet. And the repair techniques are going to be different for this than in the type 1 situation. Type 3 is cusp restriction, and this really gets into decreased leaflet motion, and really we're talking about shaving and decalcification and patch techniques. Those are not, I would say, in my opinion, terribly durable. So really, in general, I think with most of us who do this type of surgery, we're thinking about patients with type 1 or type 2 pathology. I do want to just mention some standard aortic valve measurements that are utilized when we're thinking about repairs. And the ratio numbers here aren't important, but I do want to call out 3 different measurements that we routinely make in the operating room when we're assessing valves for repair and assessing the results of repair at the conclusion of the procedure. So the first is called the geometric height of the leaflet. And this is simply the distance between the leaflet insertion point and the edge of the leaflet here. And this is just simply measured with a ruler in the operating room. And that's in contrast to what we call the effective height, which is the vertical distance from the basal ring up to the top of the leaflet. And the effective height is measured with what's called the Schaefer's caliper, and you'll see that in one of the videos. And then the third measurement I think is important for us to think about is called the free margin length, and that is just the length from commissure to commissure on the leaflet edge. I've listed a few sort of general rules that the numbers aren't that important for to think about, other than to give you a little bit of context. And so again, geometric height is critically important for determining the repairability of a particular valve. And so we measure all the leaflets prior to performing repairs. And for tri-leaflet, we want at least 16 millimeters of geometric height. For bicuspid, we want at least 19. And you want to ensure that there's enough leaflet surface area that you can effectively repair a valve. And if you're less than this, you should really think of alternative procedures. In terms of the effective height, we'll typically use a 9 millimeter Schaefer's caliper. And anything less than that, we get worried that there's leaflet prolapse. And we'll oftentimes perform a plication to help raise the height of that particular prolapsing leaflet to improve the coaptation here. So in terms of sort of very generalized rules of ease of repairability, I've listed 4 lesion sets here in order. And I think trileaflet valves with central aortic insufficiency are probably the easiest. That's that sort of El-Khoury type 1 situation that I showed before. Next, I've listed bicuspids with central AI. That's actually very rare. Much more commonly, we see bicuspids with eccentric aortic insufficiency. I've listed that next. I've intentionally left a lot of space until we get to trileaflet aortic valves with eccentric AI. This is that El-Khoury type 2 situation. And this is where the sort of red flags start to come up for me a little bit as a repair surgeon, because these are going to be more difficult valves to repair. A simple annuloplasty will likely not fix aortic insufficiency in that patient, and you're probably looking at leaflet pathology that needs specific leaflet work as well. So in terms of the general principles of isolated valve repair, I really think of this as that there's really 2 major things that we do. The first is an annuloplasty or reduction of the aortic annulus size. And there's a variety of mechanisms that we can use to achieve this. So there are external subannular rings, also called a Lansac ring for Emmanuel Lansac, who's a surgeon from Paris. There's now an internal annuloplasty ring that we'll talk about that's commercially available called the Heart ring. There are suture annuloplasties that have been described. And we've already talked about valve-sparing root reimplantation, which again, depending on the size of the Valsalva graft you choose, performs an annuloplasty as well. There are multiple leaflet repair techniques. I think the most common we think about is leaflet plication, which is shown here. And again, that's to address prolapse of the leaflet and raise the leaflet height. And then things like bicuspid cleft closures, fenestration repairs, etc. I think previously the lack of standardization has been a barrier for many surgeons doing aortic valve repairs. And again, this is in stark contrast to the situation in mitral valve repair, where we have a myriad of annuloplasty rings, neocore systems, etc., that aid in repair. And although the Heart ring is not perfect, I think it's certainly a step in the right direction of being the first, commercially available annuloplasty ring that helps standardize these repairs. And I think that makes it a lot more reproducible for surgeons. And it comes with a sizing matrix that we'll show. And I think, again, although there's certainly not perfect, I think it's a huge step in the right direction. So what does this look like in practice? So this is a 75-year-old woman with a 5.5 centimeter ascending, again, preserved aortic root, who had about 3+ aortic insufficiency coming into the operating room. And so here I've resected the ascending aorta. We're looking down at the valve. I'm doing my pre-repair assessment. Here is the sizer for the annuloplasty ring. And we measure each leaflet. We start by doing the post sutures on the commissures. And this ring, again, gets implanted below the level of the valve, obviously, at the level of the aortic annulus. So once we've done all 3 posts, the annuloplasty ring gets put in the annular plane. These are the looping sutures that secure the ring. And then these get tied down, and this helps prevent any movement of the ring or ring dehiscence. In this case, there was some fibrosis at the nodules. This is a CUSA ultrasonic device, just thinning out the leaflet a little bit. And we had a little bit of prolapse on the non-coronary cusp. So here's a leaflet plication, again, to help raise the height of that leaflet. And that gets tied down. And I thought I had a little bit of excess free margin length here on the left coronary cusp. So I did a little bit of plication to shorten that length a bit. And I was much happier with how this looked after I did that. And there's often a little bit of redundancy here, and that's okay after doing an annuloplasty. In post-repair, we got a really nice result with frankly trivial aortic insufficiency in a reasonably low gradient in the mid-teens. Okay, so this is an important video. So this is an example of an external subannular ring. And this video comes from Dr. Eric Roselli at the Cleveland Clinic. So again, no root aneurysm. So this is that subannular dissection, very similar to a reimplantation procedure. And this is really critical. I'm going to stop this here. So now, because because in this scenario, we're not performing a root replacement and taking off the coronary arteries as buttons. In order to place a subannular ring, you actually have to get below the level of the coronary arteries. And since they're being left in situ on the native root, you actually have to gain access below them, which is frankly kind of a unique maneuver, at least in adult cardiac surgery. So here, Dr. Roselli is passing a right angle below the right coronary artery. And this is, it's shown on the left. So this is a bit of a nerve-wracking maneuver, to say the least. Here are the subannular sutures, again, very similar to the situation in a reimplantation. And these will be passed through the annuloplasty band. A Duran mitral valve band is actually going to be used in this situation. There's no commercially available external subannular ring in the United States. Emmanuel Lansec has one that's available in Europe, but here we sort of improvise with various Dacron grafts or mitral bands. So again, it's being pulled below the right coronary artery there. It's obviously repeated on the left. And then those subannular sutures get tied over a Hagar dilator. Here you can see the band, the last stitch gets tied down, and that band gets tightened. So I want to shift gears a little bit and talk about bicuspid aortic valve repair. And this is being recognized as a critical concept for repairability of these valves. And this involves the commissural angle between the true commissures in a bicuspid valve. So in a Sievers 0 or true bicuspid scenario, you in general have 180 degree symmetry between the valve. For a Sievers 1 valve, which is what we see a majority of the time, that angle can vary greatly. And really what we want to see for repairable valves is something close to what's listed here as a type A or symmetrical commissural angle. We want that to be as close to 180 degrees as possible. As it gets, as the angle decreases a little bit and we get more asymmetric, it's still repairable most of the time until we really get less than 140 degrees or so. I would say this very asymmetric situation is honestly, in my hands, in most surgeons' hands, probably not repairable. Here, this is a European paper of some kind of extreme commissural reconstruction. But in general, when we think about BAV repairs in a Sievers 1 situation, we really want to see some commissural symmetry. And these type A's are going to be the most repairable valves. Sievers 0 is an excellent substrate for a valve sparing approach. So what does this look like in practice? So this is a younger patient, again, with an ascending aneurysm, Sievers 1 valve, pretty good symmetry, maybe about 160 degrees or so, with that eccentric jet. Very, very classic Sievers 1 VAV aortic insufficiency profile. So again, I've resected the ascending aorta here. The fused leaflet is sort of on screen left. The reference leaflet or non-coronary cusp is on sort of screen right. Again, we'll use an internal annuloplasty ring in this situation, and the sizer is going in there. We want to size to the LVOT to make sure we don't do too much of an annuloplasty and shrink that annulus down too much and induce gradients. So again, we start with the commissural sutures. You can see that the annuloplasty ring is a symmetric ring, is in that 180 degree configuration. And so we really, in some ways, I almost think of it, we sort of turn these Sievers 1 BAVs into almost a Sievers 0 situation. So again, much akin to the situation in the tri-leaflet repairs, the ring gets lowered into place, and then we'll do our looping sutures to help secure the ring. A standard in any Sievers 1 repair is going to be closure of the raphe. In this case, this particular patient didn't have a very fibrotic fused raphe, but we'll often debride that a bit and then perform some plications. This is a plication of the reference or non-coronary. This is the healthy cusp. We actually try and limit the amount of work we do here because this is the really more healthy leaflet. And here I'm closing that raphe on the fused right-left cusp here. And again, it's just all about getting the leaflet heights even. Here's the Schaefer's caliper coming in. So I'm measuring the effective height. I'm happy it's 9 millimeters on both sides. Nice valve opening on the post-repair. 0 leak to speak of. And most important with this, we'll talk about this in a second, is the gradient. So my mean gradient here in the operating room was 11. Actually came down to 6 post-operatively, so I was very happy with that. It was a nice big annulus. I was able to use a nice ring here, but that is definitely something that we have to pay attention to. This is just a short video of, I think, I put this together. It's kind of, I think, a key aspect is not only knowing how to do these repairs, but when to replace. And this is a 64-year-old that I wanted to repair, severe AR, mild to moderate AS, and I can show you what his valve looked like upon assessment. So look at these fenestrations here. This is the right coronary cusp. There's all these fenestrations here. The leaflet body is quite calcified. This is a bad valve, and especially in a 64-year-old, this needs to go in the bucket. For better or for worse, I replaced this valve, and I think that was good judgment. Briefly touch on again some of these medium-term results that I alluded to before. This is from Emmanuel Lansak's series of his external annuloplasty ring, fairly good results for freedom from reintervention here for both tricuspid and bicuspid aortic valves up to 10 years. The freedom from significant aortic regurgitation is something that we need to watch, especially in this bicuspid situation. I think more data is needed here, but we're maybe seeing a bit of a signal here as we get out to 10 years. In terms of the internal rings or that heart annuloplasty ring, this was early data that was just published at the STS a few weeks ago. looking at freedom from reoperation, fairly low rates. This is new technology, fairly very small patient subset here. So we're certainly still learning. And then I think that a key aspect we're watching as surgeons is the issue with gradients here. And as we really shrink this annulus, and if we're putting anything internally in the left ventricular outflow tract, what is that going to do with gradients? And I think in the trileaflet setting, it's reassuring. This is data from Duke. In the trileaflet setting on follow-up, we've seen a nice decrease in gradients. And I've actually, in the patients I've treated, I've seen the same thing. But in their series, the bicuspid patients went up to sort of low teens in follow-up. And this is definitely something that will need to be watched over time. But these are certainly reproducible techniques, and I think do work, though not perfect. So shift gears a little bit and talk about aortic stenosis in young and middle-aged patients. And in general, valves with significant aortic stenosis are not repairable. I think this is a great picture. This is a young bicuspid AS patient I did an AVR on. And this is just an amazing amount of calcium I debrided from this patient's annulus. So this is certainly not a repairable situation. And in this patient population, there has been a renewed interest in the Ross procedure to address some of these patients. And just for review, the Ross procedure involves moving the patient's pulmonary valve over to the aortic position and reconstructing the pulmonary outflow tract with a homograph. And the data for Ross procedure in adults is quite compelling, actually. And I've listed two, I think, sort of key figures that are often cited by proponents of the Ross. And the first is from again, this is from the Montreal group. This was a randomized trial, actually, looking at patients receiving Ross, which is this blue line, versus aortic homograph for root replacement, shown in the dashed red line. And this is survival over time. They also had this line for sort of, a matched control population. And you can see a significant survival advantage for Ross over the homograph, and potentially even equal survival to a matched cohort out to 12 years. If you compare a Ross procedure to mechanical AVR shown here, there's been data to suggest decreased need for, lower rates of cardiac and valve-related mortality. And this is shown here out to 25 years from this. You're starting to lose a lot of patients out here, but good results at 15, 20 years. And so that's many times in these younger patients, that's really what we're sort of thinking about is how does a Ross compare to a mechanical valve. This figure comes from a very nice review from a few years ago in JACC on adult Ross procedures. And I think, any conversation of a Ross procedure in adult, needs to have a clear assessment of both the advantages and the drawbacks of this procedure. I think the advantages are several. I think it's been shown that there's excellent long-term survival with this procedure, great quality of life in general, and avoidance of anticoagulation, fantastic hemodynamics for the pulmonary homograph, and fairly low rates of valve-related complications. There are some drawbacks. It is a technically more complex procedure, unquestionably, than an isolated aortic valve replacement. You do have potential for long-term failure of two valves, and the reoperations can be technically complex. I tend to quote patients when I'm counseling for Ross of about an 80 to 85% freedom from valve reintervention at 15 years. And that's a fairly conservative look at the literature, but that's that's sort of what I'm quoting and how I'm communicating this procedure to patients. So this is just an example of a young woman that we treated a few months back with a Ross, and just a very, very excellent result. And she's done great postoperatively. So the way that I have adjusted my thinking of aortic stenosis really depends on patient's age, but frankly, more important than just the chronologic age is really using, I think, age as a surrogate for sort of life expectancy. And I think if, as a general rule, if I think a patient has at least 25 years of life expectancy, the concept of a Ross is at least crossing my mind. And there's no question it is not a perfect operation, and it's not for every patient. But for the appropriate patient, I think it's an excellent choice. And patients do very, very well with this. Several considerations to think about. One group I think that is very interesting is the use of a Ross in the setting of aortic regurgitation, frankly, with or without a root aneurysm. Kind of a classic scenario here that's a little controversial, I think, is a patient with a bicuspid aortic valve who has kind of moderate aortic root dilatation, 4.5 centimeters or so. And the reason this is controversial, we really know that a primary indication of aortic regurgitation is a risk factor for late Ross failure as compared to aortic stenosis. And we get worried about autograft dilation over time. And it seems to be that annular dilatation, as it relates to aortic regurgitation, is a risk factor for that. That has led to this concept of a quote unquote protected Ross procedure. That's shown in these figures here. So this can be done in a variety of ways. So this is actually using that external subannular ring, kind of that Landsack ring that I've shown a few times now, to help stabilize the annulus and prevent dilation over time. This is a more extreme version of actually wrapping the entire pulmonary autograft with a Dacron graft. And this is all an effort to prevent autograft dilation over time, which is really the main mechanism of failure. One thing that comes up are these reoperations, and there's actually a fair amount of enthusiasm for a valve sparing concept. I actually think this is a perfect use for that internal annuloplasty ring and actually a Yakub procedure. That eliminates the need for getting into the subannular space, which would be quite difficult after a Ross procedure. It would be very scarred down. So I actually think that iteration of a Yakub is a perfect application for these patients. Just a few final thoughts. I think we in the aortic surgical community, I think we're all constantly learning, we're all constantly improving, and I think that's what makes this very fun, very exciting. I think in general, I will sort of fail in what I consider is sort of, my mission in this space. If my techniques and my results don't evolve over my career, my hope would be that this particular talk will change completely in 5-10 years, further down the road. We're obviously not perfect. None of these techniques are perfect, but we are trying to innovate, trying to improve. And the last part about innovation, this is a picture of me with Joe Bavaria at the University of Pennsylvania. And he really instilled this idea of constantly innovating, trying to get better, being self-critical, and really being a leader in the field and moving things forward. And that's something that I try and carry, as I sort of begin my career. Just a couple conclusions. I believe aortic valve replacement has consequences, and it's very important that we understand this, especially as it pertains to younger patients. And the second, I believe retaining the living aortic valve complex with valve repairs, valve sparing root replacements, or Ross procedure has value in properly selected patients. Thank you for your time and attention, and I'd be happy to take any questions.
That was a fantastic talk, Chris, and you can tell, I mean, we had 140 people listening, and most people stayed on the entire time. So I think attests to the value of this. And I always learn a lot. I'm sure everyone else does too. Seeing the surgical approaches and hearing your thoughts. I mean, this is so important for those of us who are referring patients, and also, for anybody doing imaging, to understand both before the procedure what it is you want to know, and how we should manage these patients afterwards. And as people are formulating their questions or raising their hands, I just like to put this in the context of the guidelines. That the ACCHA valve guidelines just came out in late December. And the algorithm you showed for the choice of Ross versus a valve is quite in line with the guidelines. We recommend under age 50 for aortic stenosis or regurgitation. A mechanical valve is still listed as the first choice, but there is a 2B, which means might be considered recommendation for a Ross procedure for both stenosis and regurgitation in younger patients. And whether you use 50 or 55 like you, the guidelines consider age simply a surrogate for life expectancy. And I think the only reason it's a 2B and not higher, I agree with you, the data is very compelling. The concern is that the data is compelling from institutions that are really good at it, and that it's not transferable to every medical center everywhere. So that's why the 2B and the text mentions that it should be at a place that can do it. So it's fantastic that we can do it. Now, the newer repairs, I think, are very exciting and are not in the guidelines at all, because there's very little data, which hopefully will accumulate. But I think, like the analogy to mitral valve repair, this is going to be a complete game changer. If we can do valve repairs in our younger patients with bicuspid valves, which is a huge population, we'll really, move the needle earlier in the disease course. We've been waiting till very end stage disease when the only option is a replacement. So this will totally change things, just as mitral valve repair did.